Great. Thank you very much, David. Good afternoon, all of you. Are you still awake? We had a nice lunch and a bit of rest. Very exciting morning, and I think this afternoon hopefully will prove to be just as interesting and as exciting as the morning. As David said, I'm currently a professor emeritus at Cornell's medical school, the Weill Medical College. I'm trained as a psychologist. I've been in prevention for, my God, I was talking to Tony at lunch since we were just out of high school, it seems, but well more than 35 years. I've been on the Cornell faculty alone for about 35 years. After spending the bulk of my career at Cornell, I retired from Cornell. I mainly am focusing as an emeritus professor on work looking at bridging the gap between science and practice. And I'm doing that through an organization I created called National Health Promotion Associates, and another organization I'm working with Rico Catalano and David Hawkins and Jeff Jensen and a number of others on, called the Coalition for the Promotion of Behavioral Health. Let me just take a second to remind all of us, before we get into this discussion today, of where we've been and where we've come from. We've really come a long, long way. It's been a long, hard, winding road. But as David said, we started out not all that long ago with essentially no effective interventions, no effective prevention programs. Most of the early prevention efforts focused on trying to increase knowledge or change attitudes, and even in those cases where they were able to do that, they were not able to have an impact on the target behaviors. In the area of tobacco, alcohol, and illicit drug use, it's also the case they were not only ineffective, but as you can see on this slide, some programs actually increased drug use, as Nan Tobler found in a review she did back in 1986. And so what that tells us, the lesson we can learn from that, is that untested ideas are not just ineffective, they actually can make things worse. So we have to be very careful. So looking back at where we've been, at these early approaches that were largely educational, and didn't really have an impact on the target behaviors that we hoped they would. We then went through a paradigm shift to a risk-focused approach, one that many folks in this room have been involved in, including David and Rico, looking at risk and protective factors. And this is a very general look at the prevention research cycle, but it tells us what we've accomplished so far by focusing first on developing a greater knowledge base with respect to etiology, learning about the risk and protective factors, the developmental course of many of these problems, then developing interventions based on that information, conducting pilot studies, small efficacy trials, effectiveness trials, and then moving, hopefully, once you've demonstrated you have effective approaches, to disseminating those approaches. And that, by and large, is where we are today. And in my view, that's really the thing that we need to place the greatest emphasis on. At the same time, continuing to do research and fill a number of important scientific gaps. So as David said, over the last 35 years, we've made tremendous progress, and there are now over 60 effective programs and policies that have been identified by various groups around the country, including the Blueprints group. They've been able to demonstrate that you can prevent behavioral health problems, substance abuse, delinquency, violence, for example, mental health problems such as depression and anxiety, and a number of independent economic studies have shown that prevention can save money, anywhere from $2 or $3 for every dollar invested to as much as, in some cases, $30 or $40 for every dollar invested. So we've made a great deal of progress. We've also made progress with respect to advancing scientific rigor and standards of evidence, both, again, with the Blueprints initiative and by work done at SPR with two initiatives there. One that was started while I was president of SPR and continued and brought to fruition, I think, when David, you were president. The first standards of evidence were published with Brian Flay as the lead author. And more recently, there was another iteration, an updated version of this, which provides an even more rigorous set of standards, some of which may be at the moment unattainable or at least aspirational. But Denise Gottfredson and others led that initiative, and that was just published last year. And then finally, John Barron and his group at the Coalition for Evidence-Based Policy has this top-tier initiative, which is designed to identify the very best preventive interventions. A number, as you know, of major federal agencies and professional organizations have had their own initiatives to identify evidence-based programs. Programs initially were called research-based programs. We've gone through this iteration of names, and we're now calling these evidence-based programs. And they've been identified and acknowledged by a number of major government agencies dealing with a variety of problem behaviors and health compromising behaviors. Here's just a short list, a few examples of some of these programs. Another interesting thing that we've learned in the prevention field, and Tony Biglin had a book on this, is that some evidence-based programs can prevent multiple health problems or health behaviors, because a lot of these problems share risk factors. They're both shared and unique risk factors, and to the extent that they're overlapping risk factor, it suggests the exciting possibility that a single intervention can have an impact on multiple problems or multiple problem behaviors. Now let me say a word about the work that we've done over the years with a program called Life Skills Training. The program is designed for middle school kids to hit kids right at the beginning of the critical risk period for a lot of problems. It focuses on teaching a set of self-management skills and general social skills in order to decrease substance abuse and violence motivations. That is the internal motivations to engage in these behaviors. It's also designed to decrease vulnerability to pro-substance abuse and violence influences coming from the media or from one's peer network, and to promote resilience. And then with respect to the specific problem domain of substance abuse and violence, it teaches resistance skills and refusal skills so you can more effectively learn to resist peer and media influences, to make healthy decisions, and to promote healthy attitudes and norms. The program initially was 1 year, but then we quickly learned that you needed to also include booster sessions, so it now consists of 3 years, an initial year of intervention, 15 class periods, 10 class sessions in the second year, and 5 in the third year. We use interactive teaching methods, which again, reviews have shown to be more effective in conveying this content to kids in this age group, getting them involved. It needs to be engaging. We provide provider training to the teachers and other health professionals who are implementing these programs, and then, of course, technical assistance to help them if they experience any bumps in the road. Over the years, we've conducted a lot of large-scale randomized trials, going from short to long-term duration, focusing initially on tobacco use and then moving to focusing on alcohol and other forms of substance abuse, and then more recently on violence. There are a number of challenges of going to scale, and I don't really have time to get into those challenges, but let me, given the focus of today's panel, make a few comments about the advantages of programs, because my job is to come down on the program side, and that fits well because I'm a program person. So what are the advantages of proven programs that have been tested and proven effective? First, they have detailed intervention protocols. The interventions, if they're well designed, are carefully specified and carefully operationalized. They're well tested. They use well tested methods, for example, various kinds of interactive teaching methods. And they also contain user-friendly materials that make it easy for providers to implement the program. They can utilize existing dissemination structures, and they have available training and technical assistance and tools for assessing implementation fidelity, not only on a large global level, but on a fairly granular level to look at how well the interventions are being implemented and to see if these programs are being implemented with sufficient fidelity. Well, what about the other side? And I'm saying some of these things to help provoke discussion later in the panel. What are some of the disadvantages? Well, I think at the moment there's insufficient understanding of the active ingredients or the core components. We've talked about this a good deal today, but there's been relatively limited research about the active ingredients or the core components. And so if we're to move towards principles-based interventions, to a large extent at this moment in time, we would be making educated guesses about what the active ingredients are or the underlying principles. Second, with respect to fidelity, our fidelity data and the data that other folks have amassed over the years shows us that if programs are not implemented as designed, they're less effective. And there tends to be more of a linear relationship. The less well they're implemented, the further they depart from the design or the program as it was intended, the less effective they tend to be. With a principles-based approach, there's likely to be a high degree of variability in terms of the operationalization and the specification of those principles and how they actually manifest themselves in any given intervention. At this moment in time, if you were to put together a set of principles, they haven't been tested. So at the moment, the principle approach hasn't been tested, and in fact really needs to be tested if we're going to move forward in that direction. And finally, and this is a concern I have, and that is that we've made a great deal of progress. Most of that progress is because of the development of evidence-based programs. And if we move in this other direction, the possibility is that we may, at least initially, give license to folks in various settings to essentially go back to implementing their own programs or implementing programs that may be similar to the programs that have been tested and shown to be effective, but really not be effective. And by doing that, we could essentially undermine the progress that we've made in the field. So in order to unleash the power of prevention and capitalize on the past 35 years of research, I think it's important at this point in time to stick to programs that have been tested and proven to be effective. We now have within our grasp the tools to reduce mortality and morbidity by using evidence-based programs. And what I think at this point in time the focus should be, and while we should continue doing research that may ultimately get us to the point where we can have principles-based interventions, the emphasis now should be more on promoting the dissemination of programs and support systems that are likely to be effective and have been proven to be effective. So let me just conclude by saying at this moment I think it's premature to focus on principles-based interventions. We still need more research to identify active ingredients, to test those principles-based approaches. There's the potential to undermine the progress we've made over the last 35 years if we move too quickly towards principles and away from programs. As I said, the power of prevention, the possibility of having an impact on the public health problems that we're concerned with and reducing mortality and morbidity is within our grasp. We should instead focus on developing new and better funded initiatives to disseminate evidence-based programs and not focus at this moment in time on untested approaches that are based on a set of principles extracted from these interventions. Thank you.